Hello, it's October 28th, 2016. This is the RheumNow Weekend Review. I'm Dr. Jack Cush, Executive Editor of RheumNow.com, and this week in the news on RheumNow, a nice report that talks about predictive features of juvenile onset arthritis brings back an oldie but goodie, and that is a child with a limp should be considered to have JIA and should be investigated. Often a limp is the most common presentation and obviously speaks to a lower extremity involvement in a child, often a preschooler, who may not otherwise complain, may be very, very active, but a limp may be the telltale sign of the onset of JIA, often the oligoarticular type. Anyway, this review looked at other predictive features and underscored that limp. We found two reports in the last week that actually have the same message, and that is that patients with rheumatoid arthritis have a 1.5 to 2.0 fold increased risk of hearing loss. Can't say that it's something I've ever noticed or made a big issue out of. I do have a few patients who have hearing losses or who are using hearing aids, but it's not something that's commonly tested for, and maybe it should be something we look at. So it is on the agenda, and it may be something that should be important. In the course of looking at this literature, I also found reports of hydroxychloroquine-associated ototoxicity. We're certainly aware of the macular toxicity and a lot of buzz in the last few weeks about the new guidelines for ocular screening with hydroxychloroquine, but the occurrence of ototoxicity is not something I really was familiar with, but there actually are a number of well-documented cases that underscore this possibility, often related to duration of use rather than dose per se. Some have looked at ways of predicting who's going to respond to what drug, and the inevitable or the elusive biomarker search continues. A group of investigators actually looked at gene expression in a cohort of patients who were taking TNF inhibitors and found it was actually the neutrophil genes that were most predictive of a TNF inhibitor response. In particular, a panel of three of these, CMPK2, IFIT1B, a kinase, and RNase3 put together actually had like a 95+% predictive value, predictive ability in identifying patients responding to TNF inhibitors. It says a lot maybe about a new way of approaching the problem. It also says maybe a lot about what TNF inhibitors in fact are doing above and beyond the inhibition of TNF, and what may be the most important mechanism of action might be related to neutrophil function. So that's something I think that we'd like to see more of going forward, more research in this particular area. A comparative study looked at patients who have spondylitis, either of the tuberculous type or of the pyogenic type, and compared some of the features and found that tuberculous spondylitis patients were more likely to have extraspinal manifestations, a history of TB, and a positive IGRA. You would think that patients with pyogenic spondylitis would have more fevers and more abscesses, but in fact, this particular comparative study showed that those features were more common in patients with tuberculous spondylitis. Economic news looking at the cost of biologics and specifically the cost of biosimilars. An interesting move happened this past week in Ireland, where the introduction of Benepali, the etanercept biosimilar, used to be called SB4, made by Samsung, it hit the market, and Pfizer has responded by saying it would match the price and cut the price of Enbrel to match the price of Benepali, its competitor in that Irish marketplace. I think it's an important news item because it's probably what will happen with other biosimilars in other jurisdictions, especially in the United States. We know in the United States that there's going to be the new introduction of Inflectra, the biosimilar to of infliximab or Remicade. J&J has responded this week by saying it will compete with the price cuts of Inflectra, which are only going to be 15%, by the way, through a variety of innovative contract options, discounts, and rebates to payers, providers, and pharmacy benefit managers. So you see, it's going to get a little bit dicey and a little bit competitive when these drugs hit the market. So this 15% discount, which I think was not nearly enough when it was announced last week, will probably be cut even further as we have more versions of infliximab and more versions of adalimumab hit the marketplace. A nice study looked at the features associated with nodules associated with gout, the tophi of gout, and what makes a gouty tophus erode. The tweet that we put out there was that rheumatoid nodules never erode, but a nodule that erodes and has an exudative release is way more likely to be a tophus related to gout. And in this particular study, they showed that the features that predicted erosion and ulceration of a nodule were the patient's age, the size of the nodule, and the loss of protective sensation. Good clues to look for. A quote coming from the one of the movies that I thought was interesting that I'd recently seen. This is from the Exotic Marigold Hotel, I think is the name of the movie. And Sonny Kapoor says, "Everything will be all right in the end. If it's not all right, it's not yet the end." I like that quote, and I actually wrote a blog about it called "Prescribing Hope in Medicine." There may not be enough of that going on. You might want to look at that particular blog. A meta-analysis of 3 different studies has continued to show a point that's been coming up the last few years, and that is in patients with acute gout, it is safe and it is reasonable and smart to actually start urate-lowering therapy with allopurinol during the acute attack. That the use of allopurinol in that situation will not prolong the attack, will not increase the pain, and in fact will actually lead obviously to sooner resolution of the patient's hyperuricemia. So something to consider in your patients who are starting out with a diagnosis of gout who may need urate-lowering therapy. We've often known that rheumatoid arthritis is an erosive disease, but interestingly, African Americans with rheumatoid arthritis have less erosive disease. A recent study looked at both cohorts of African Americans and Caucasians and found that the African Americans who had erosive disease, which is unusual, was not associated with ACPA as it would be in Caucasians, but instead was associated with PADI4 and PADI3 antibodies. So something to consider. It's not a routine test that we do, but it may explain why some African Americans may not have erosive disease. I posted a reminder about the 5 big mistakes in methotrexate use and prescribing. Number 1, using methotrexate daily. Oh my goodness, this gets me very unnerved, but you know, anybody that's seen patients who get in trouble with methotrexate often have a misinterpretation of instructions and do take the medicine daily, whether it's 1 pill a day or 7 pills a day. Daily dosing will get you in trouble, so make sure you enforce the use of this drug only once a week, no matter how you give it. Second, using methotrexate without concomitant folate or folinic acid therapy. Third, using methotrexate in patients with renal failure. The worst cases of pancytopenia and hospitalization are usually in that context. And using methotrexate number 4 without the use of routine labs. There are a lot of specialists and primary care doctors who often will prescribe or continue to prescribe methotrexate but not get routine labs. And there are guidelines on that. I do it monthly times 3, and then after that every 3 months, assuming all the labs have been normal. And the last one is using methotrexate in the presence of hepatitis B surface antigen positivity. That's a recipe for hepatitis B reactivation and bad outcomes. Type 1 diabetes has been shown to be associated with a number of different autoimmune diseases, including, and most commonly, autoimmune thyroid disease, especially Hashimoto's disease. Celiac sprue, rheumatoid arthritis, Graves' disease, and vitiligo follow behind that. We reported on Thursday this week the results of the posture study, which are found on clinicaltrials.gov. This is an as yet unreported clinical trial of Apremilast in patients with ankylosing spondylitis. There was a 36-patient pilot trial that showed some encouraging results, but nonetheless non-significant clinical measures. But enough was seen in that trial to prompt a much larger study. In fact, this trial has completed its initial phase of 24 weeks of blinded therapy. The primary endpoint was an ASAS-20 response at week 16. 490 patients were enrolled and either received placebo or 20 or 30 milligrams BID of Apremilast. And at the end, at least at 16 weeks, the primary endpoint, the 30 milligram BID group had an ASAS-20 response of 32%, whereas those on placebo had a response of 36%. Oops, not quite what you'd expect, but nonetheless, the trial is ongoing in open label extension. There were no other major issues. The adverse events were largely the same in both groups. We're waiting for more data about things like enthesitis or peripheral joint involvement. There were a few safety signals in that. There were more SAEs in serious adverse events in the 30 milligram Apremilast group compared to placebo, 6 versus 1. And there were more treatment-related dropouts in the Apremilast group, 12 versus 6. So that's pretty much it. And I think that you won't see Apremilast being pursued for use in spondyloarthritis in the future. There's a nice study that looked at a meta-analysis of what happens when patients receive knee replacements. Is it safe to do bilateral knee replacements at the same time, or should you do serial or one followed by the other knee replacement? The study ended up showing that in 18 studies that were combined with over 65,000 patients, that the patients who had bilateral knee replacements had a much higher risk of mortality. That included a 30-day, 3-month, and 1-year post-op mortality rate that was 1.85 to 3-fold higher in those who received the bilateral knee replacements at the same time. The other interesting and important outcomes in knee surgery, DVT, infections, cardiac complications, in fact, were the same between both groups. So that's encouraging, and basically means that for patients or physicians who want to do bilateral at the same time, you have to be careful and select the right patient, certainly those who have the least amount of risk factors and cardiac risk factors. And lastly, I think a very important paper was published in the last month in Journal of Immunology, and this is, sort of unveils the etiology of Kawasaki's disease, a childhood disorder known for strawberry tongue and cardiac complications. These results actually showed that Kawasaki's disease is an IL-1 driven disorder. We know that from clinical evidence where patients who have refractory Kawasaki's disease not responding to aspirin, they actually respond quite well to IL-1 inhibition with anakinra and like drugs. In this particular study, they looked at a very large cohort of Kawasaki's patients and found a polymorphism of inositol triphosphate 3 kinase C that actually leads to intracellular calcium signaling being increased that drives the inflammasome and NLRP3 in an autoinflammatory-like manner to increase the production of IL-1. So hence, this is an IL-1 driven disease. There's a known now genetic defect that might be useful either therapeutically or diagnostically in the future. That's it for this week at RheumNow.com. Go to the website to see these citations and find the links for these important reports. Please go to the website and register, and it would do me a great favor if you did that. And if you're interested in getting the podcast of this, you can get it at iTunes, and you can download this and a bunch of other past episodes as well. Be sure to tell your friends to sign up at RheumNow.com. We'll see you at the ACR. Have a good weekend.